Hi, welcome to Healthcare Financing System, understanding how we pay for healthcare and why it matters. In this lecture, we'll explore how healthcare systems are financed and why it matters. Understanding how we pay for healthcare is essential to understanding how it's being delivered. Healthcare financing determines who gets the care, what kind of care is delivered, and how efficiently a system operates. It influences incentives, access, and equity in any healthcare system. So the key things about the golden triangle, the iron triangle, where you talk about the trade-off between cost, quality, as well as access. So you can have a low-cost system, the problem is the quality as well as the access, or you could have a low access, high access system, and the problem will be the cost or the quality, or you can have a high quality system where the problem is with the cost as well as the access. There are three main functions of healthcare financing. Firstly, how do you collect the revenue, where the money comes from? Is it through taxation? Is it through a national insurance system? Or is it going to be out of pocket, or it's a payroll tax? The second part is risk pooling, spreading the financial risk. Because in any case, the chance for an individual to have a high risk spending is relatively low, but when that happens, the individual is unlikely to be able to pay for the catastrophic illnesses. Purchasing, and this is covered previously, how the funds are used to pay the providers. So in terms of the types of revenue collection, it can be general taxation, example, the national health system in UK. This is quite straightforward. Money comes for general taxation. You can have social health insurance like in Germany, where employer will sponsor the insurance, so they have to pay for it. What's important is that it is going to be portable, which means that if you change your job, you do not lose the insurance. Compare this with Singapore. If you change your job, good luck to you. The new employer may not cover your insurance from the employer point of view because of pre-existing illnesses. Private insurance, an important part, especially if you want the type of care and something that is going to be better than what the government provides. So that's quite important. Out-of-pocket payment, straightforward, you pay for your healthcare cost. In terms of risk pooling, obviously the larger risk pool, the better the cross-subsidization. So in this case, there's this thing called the spiral to problem. Okay, so for example, when premiums go up, what happens is that the patients who think they are low risk, they will not subscribe to the insurance anymore, and therefore the risk pool increases. This will require the premiums to go up even more, and therefore more and more people will drop out. So it's actually a spiral to causing the remaining pool to be super high risk and premiums need to go up. As a result of this, it's very important that we make a few things. Number one, make it compulsory, or for those who do not want to join the risk pool, they have to pay a penalty. For example, in UK, that's what they do. So contrasting in Singapore, when private shield plan goes up the premium, this will cause lower risk individuals who think they will not benefit to drop out, increasing the risk pool. So this is something that we need to be very careful of. Fragmented pool, of course, leads to inequity and inefficiency. So in Singapore, you need to ask yourself, do we really need so many private shield plans? That is a business decision. Actually, a lot of times a private shield plan is an avenue for the insurance company to get other more lucrative insurance like life insurance, insurance-linked policies, and things like that. That's another lecture. If you want to, you can cover it. But for now, just remember that fragmented pools leads to inequity and inefficiency. Ideally, it's compulsory, broad-based contribution, not just for individual, but from companies, basically those who can pay. So in certain countries, it's actually income adjusted. Those who can pay will pay more, and those who can't pay will pay less, which is fair, equity. So I covered this previously. Fee for service, this is quite common. You buy a plate of chicken rice, you pay $1. So now it's $3. You buy 2 plates, you get $6. If you buy more, there can be some bulk discount. But anyway, the more you use, the more you pay. Capitation, this is fixed per person. So this is incentivizes as long as the person stays in the in a pool to actually focus on prevention so that you don't claim in future. But if this capitation is mobile, which means that 1 year is in, 1 year is not in, then any amount spent on prevention is actually wasted, because what you prevent actually benefits the next provider rather than yourself. Diagnostic withdrawal group pays per episode of admission. This encourages efficiency, because no matter how many days you stay, you're going to get the same rate. So there's efficiency drive towards, we call this technical efficiency. We try to stay as short as possible. We need to balance against readmission. So these are the type of things to look at. Increasingly talk about extended DRG. So this extends beyond the inpatient, but also to the community as well as outpatient treatment. Pay performance links to quality sounds good, but how do you measure performance? Who performance? Is it process outcomes, process measure, or outcome measure? What if the patient do not take their medication, do not go for follow-up? Will the provider be penalized? These are some questions to ask ourselves. What is strategic purchasing? Basically, it's the use of funds to buy high-value services. Again, it involves who to buy, from who, and how. So a lot of times it's really about setting the budget as well as setting the goals. This potentially could promote accountability and quality, because when you purchase services from provider, there is certain service level agreement that needs to fulfill. For example, if I pay the general practitioners on a fee on a per capitation basis, and they only open 3 hours a day, that is not going to be very useful, because access of care will be affected. So you forcefully have to agree that, okay, you should open from 9 a.m. to, let's say, 6 p.m. That's why there's a lot of negotiation with after hours. For example, in UK, that's what they do. But ultimately, it's important to set certain guidelines, or not just how many you're supposed to see. Otherwise, in the end, you may just see one patient a day, which defeats the purpose, because this is the amount they actually collect. So service level agreement is important to ensure that they do provide a service as required, as agreed on the contract. Case example, Singapore has this thing called the 3M1S, which is the government subsidies. So for subsidized care, government pay a subsidy that is now means tested, which means that the more you earn, the less you get, which is fair in terms of equity. MediSave is actually your own savings. So you actually have this, they call this a managed savings account in some of the countries. This is an idea of savings for what you need. The only issue is if you have no job or low paying job, there's not much you can save. MediShield Life is not compulsory, but it's catastrophic insurance. It doesn't cover everything. There's a huge co-payment and co-deductible. Deductible and co-payment, as well as mainly for catastrophic illnesses and mainly for subsidized ward. For private wards, which if you're interested, I can cover more. There's actually proration, which means that they actually decide how much can be paid for private wards to discourage people from staying in private wards. The key thing is emphasize personal responsibility and cost consciousness, achieve high outcomes at modest costs. So Singapore spent about 4-5% GDP on healthcare, which is amazing for the amount of care they provide. One of the things is that there's also MediFund, which is not covered here. So MediFund is a safety net. So for those who really cannot pay, once they have exhausted all means of payment, the government will step in and pay for it. This MediFund used to be you used to need to apply in different settings. Right now, they're trying to harmonize. So I think there's a lot of good things that's going on. Comparing healthcare system. So you have the beverage system, the UK system. This is tax finance, publicly delivered. The idea of how this system come about must go back to history. So after the Second World War, UK was in a very sorry state. Everybody felt that we need some help, we need solidarity. That's why there's a tax system that will help everyone regardless of the need to pay. So it's actually care. You got to pay a single cent. Actually, you do pay. You pay in terms of taxation. But there are people who don't work. That's another question. Next one is a Bismarck system. This is the Germany system. They actually started off as a social insurance, and they got in the companies to pay, and then slowly cover everyone, even though you're not working. The main thing is that it's private delivery. You have the national health insurance system. There's Canada, single payer. The good thing about single payer, that is actually key thing is that it actually have low administrative costs. Interestingly, Taiwan. Okay, Taiwan actually followed US in terms of the Medicare system, but the Medicare system is only above 65 years old. So what you can think about it is Taiwan system is Medicare for all, which is something that unfortunately I don't think is in US is possible to implement because there's a lot of belief in personal accountability and things like that. No interest in big government, and there's a lot of private insurance that's already in there. I think United Care recently had a huge drop in share price because it announces poor performance, financial performance, as well as the so-called Medicare private, what's that called? Medicare, the private Medicare, can't remember what's that called. Basically, they claim more than expected, and therefore you set aside more money for that. Yeah, so that's the private Medicare. Yeah, I think Medicare Care D. Yeah. Okay. So some countries like the lower middle income countries is out of pocket dominant, which means that the government is too poor or too busy with other things that they can't really finance the healthcare. So a lot depends on yourself. But all is not lost. You still depend on philanthropy. So like for example, things like Gates Foundation, WHO, all these sometimes they step in to provide certain needs, especially when there's a outbreak of things. So these are the main ways that healthcare is being financed. Case study, I kind of mentioned. So in the earlier slide, we talked about the MediSave, which is the personal savings, government subsidies, as well as insurance, which is a catastrophe insurance, doesn't cover everything. There's a deductible, which means that you need to spend a certain amount. I think it's $5,000 or $6,000 before the insurance kick in. So you need to pay for the first $5,000 to $6,000. Yeah, these are the things you can think of. Why you do this is that you want to have the lowest premium. If you have a low deductible where the insurance kick in from the first cent, then your premium will be higher. They should try to do that for a private shield plan. So you have this thing called the what's that, riders, which means they cover for the first cent, which means it covers all the deductible, everything. Sounds good in theory, but in practice, this is actually a problem because if people claim, and people do claim, the insurance premium will spiral rapidly upwards. So this spiral to the bottom. Insurers make losses. So when they make losses, they need to raise premium. So when they raise premium, then those lower risk people think, hey, I don't want to pay this too much. So they drop out. So once they drop out, risk pool increases, and then they have to raise premium further. And this is a spiral to the bottom. Yeah, the term is spiral to the bottom. So in Singapore case, we encourage individual responsibility with safety nets. There's some cost savings mechanism promoting prudent consumption. So before you want to use care, especially those that are elective, not so necessary, you do think about whether you really do need it. As I mentioned, we achieved quite a good health outcomes with relative low public spending. So this is something that's a good thing. We need to applaud Singapore for that. How to improve the Singapore financial system? Well, we don't have to really dismantle the whole system. First thing is increase subsidy is important. Why? There are some vulnerable population. So I know MediFund does work, but what if you are too rich to qualify for MediFund, but too poor to either buy private insurance, or you can't really pay the co-payment or deductible? So we probably need more subsidy. So for those who don't know or those who know, there's actually the Merdaka Generation Package as well as the Pioneer Generation Package that does help to increase subsidy. So in that sense, Singapore has been moving in the right direction. Long-term care financing for aging population, yeah, this is something that's important. That's why Singapore have this thing called CareShield, used to be ElderShield. So at least those with at least 2 or 3, I think if you have at least 2 ADL that is affected, you do get some cash payment. That is something that is good. Whether is it enough for everyone, whether it can be improved, all these things are the details, but again, Singapore is moving in the right direction. Simplifying the scheme navigation for user, yeah, this is something that we always talk about, but maybe we do have some ways. We need to really, well, now there's AI, there's a chatbot, maybe you can really explain the schemes in a simple manner, because actually a lot of people don't understand it. Therefore, some people are actually overinsured. What do I mean by that? You have MediShield Life, which is basic. On top of it, you have your employer insurance plus your private shield. So to a certain extent, you are actually double counted. Then you may have catastrophic illness insurance, you may have hospitalization accident insurance, you may have income shield. So there's some area of duplication. Could we really rationalize? This is a question to ask ourselves. And finally, can we strengthen strategic purchasing? So which means that can we better pay? So instead of paying as a block budget, things like that, we may want to pay for performance, value-based healthcare, benefit case financing, which is to me a very risky thing. What this means is we could potentially say, if the patient recover, I'll pay you the full rates plus the profit. If the patient don't recover, I'll just pay your cost plus. And if the patient die or what, you may not be getting payment. So all these things are ways to encourage for performance. But what the problem is that you tend to get people to actually avoid risk. What we don't want is doctors to avoid risk. So with a high risk patient, they want to treat because if I treat, I may not get paid, even if we get paid adequately. So this is something that we do not want to. This leads to care rationing. I think at the end of the day, it's something that we really need to have a conversation. What are the behavior we want our doctors to have, and what are behavior that we do not want our doctors to have or providers to have, and that will actually be a good way to design a healthcare system. Okay, finally, in summary, the financing or determining how healthcare is being assessed, delivered, and sustained, we need a balance between efficiency, equity, and incentive is key. It's not so simple to design incentive because there's always this thing called unintended consequences. At the end of the day, we do need to design an incentive so that it doesn't promote perverse incentive to do things. And of course, policymaker, you must adapt the financing model to local context, whether you are from UK, Australia, New Zealand, US, any countries. At the end of the day, how you design your healthcare system, health finance system, is depend on what is the existing system, what is the problem you face. Is it in terms of quality? If that's the case, maybe with time you need to have some pay for performance. So like for example, US, the quality is quite okay. The issue is the cost. Then you need to focus on how can you make a lower cost system. Then for certain countries where quality is an issue, how do you improve the quality? Then for UK where access is an issue, where there's long waiting time, how do you improve the access? So I don't have an answer for everything, but it really depends on what is the problem. Focus on one thing at a time. You can't solve all the problem, and sometimes when you solve one problem, you may worsen the other things. Yeah. So thank you for listening. Have a great day ahead.